All right.
No, you're loud and clear.
They've asked us to do prone lateral at the thoracolumbar junction. It is very loud in here. So I don't know if you guys can see the cameras very well, but this is caudal, this is rostral. I've marked out at the L12 level. And one of the things to be aware of, if you are planning to do a lateral up this high in the spine, we'll be dealing with the rib cage. So have a very low threshold to place a drain, some people will want to do a chest tube. You can just do a suction drain. It can work as well. But knowing that you may end up in the chest very quickly, you may have to deal with the diaphragm placement, and trying to address that is one of the concerns here. So again, this is anterior and posterior. So we've kind of started our dissection here. You can see here external obliques and coming down, and this is a rib here. Let me see if I can show this to you better. But we're actually working in between the ribs in this space. We have our team from ATEC here with us, and they actually have bolsters here in order to... Okay. So, no, you're fine. Okay. Well, let's go to X-ray then. I guess you guys can't see what I'm doing. So we can, I may need to take a rib in this case, so we can definitely do that if needed. But we'll start here, just trying to get our localization. So you want to definitely be doing blunt finger dissection, trying to kind of peel that peritoneum or the pleura away to make sure that you're doing your best to stay out of the lung. And then once we're down there, and you may need an actually longer incision in order to get down to the actual spine. So if some people will actually do a 2-incision technique in the rib cage. I think that would be pretty traumatic. So I would try to avoid that. So let me see if I can get us down onto the spine here. Okay, let's get a shot. All right, so better to be lucky than good. So I'm actually on my disc space there. So that's our L12 level. I'm gonna place a guide wire. Okay. And we're gonna do sequential dilators here. And with this system, it's kind of a fixed set of retractors. So this will give me my approximate length. So it's looking like about a 140. And with this system, the real challenge is getting the appropriate docking. So you can see I'm slightly anterior, but this does allow for placing a shim and adjusting relative to that position, which is nice. So I'll place my tubular retractor over. And why don't you give me the little rotation? And this goes up here. So this will allow me to kind of keep my hand out of the way, shot. And this is nice because it will allow me to, I don't know if you can see the arrows there, but that'll allow me to redirect the retractor in order to try to get orthogonal. Shot. All right, and so that looks pretty good. I'm just going to rotate slightly posterior. Shot. Shot again. Okay. And then come up. Shot. So you can see those arrows there. I'm slightly anterior. And so let's see if we can adjust from this position. Shot again. So you can see that's a little bit more lined up. I actually would prefer that to be slightly more posterior in terms of my docking position. But for the sake of time, we'll see if we can work with this within the system. And shot again, please. Slightly off, yeah, why don't you loosen that up for me? Shot there. And one more time. Great, save that. Okay. So I'll take my retractors out, and why don't we come out with the C-arm for just a second so we can try to show a little bit better what's going on. If you just want to slide straight down. So typically what I would do here is place a shim. I know that's a little bit anterior positioning here, so I'm going to want to lock that into place. And no neuromonitoring here on the cadaver, but obviously a critical part of this procedure is using the neuromonitoring. Less of an issue here, higher up in the spine as opposed to further down. And do we have lights or? Mm-hmm. Great. So we'll see if we can try and give you a view of what's happening here. So again, I've locked this into position anteriorly. I know my retractor is slightly anterior compared to where I'd like it. So I can use this retractor to dial posteriorly in order to give myself more room. And so you can, if you can see down there, but that is our working window. So let's have you come in for back in for a lateral. All right, and so you can see that shim is definitely anterior. I would like to adjust that a little bit more accurately. If this were a real patient, I would not have accepted that. And then you can see the alignment there, just slightly posterior. I am going to need to be working towards this edge. Let me see. Shot here. So you can see I'm going to have to be working towards the caudal aspect of my working channel. And I actually do want to try to adjust that just because it's going to make it much more difficult to get into the disc space if you don't have this retractor well aligned. And I need the crank. And this can be a challenge. As I said, I'm kind of working against the ribs here. So you really want to make sure that you're shot. And shot there. Yeah, I really want my wire in here. Disconnect this. Shot. And shot again. See if you can lock that. Shim. And with this system, I definitely think this is part of the more challenging part is getting the retractor aligned. Once you have that, it really turns into a pretty standard lateral case, which I'm sure we're all familiar with doing the discectomy. So once we can try and give you a better image. Shot. Again, so that's a much nicer view there. You can see we're working right down the disc space, and we'll come to an AP. We'll take a knife. I'll take a call, please.
So how are you doing there, Amir? Almost ready?
All right, give us a shot.
Yeah.
Okay, you're going to want to work back towards you a little bit. And I do like, you can see that I'm sitting on a stool. One of the things that people will like to use is using an oblique position if you'd like to stand. I prefer to be sitting on a stool because I know if my hand is orthogonal to the ground or parallel to the ground, I know that I'm orthogonal to the disc space and can really work safely without getting anterior or posterior. Give us a shot, please. Okay, so you can see there, I'm going to work towards my contralateral side. Shot. Okay, as I get close, I'll really choke up on this to prevent plunging. Shot. I have my contralateral release. And again, from here, it's really a pretty standard lateral case. And if you're familiar with working in the lateral decubitus position, it's really much of the same. Shot. Again. Okay. Take a pituitary. And again, I can go ahead and do my discectomy and place the cage, but pretty standard fare for those of you that are comfortable with lateral. And again, I really like being able to work parallel to the ground here. And I don't know if you can get a focus all the way down the pipe. I know it's challenging here with the camera angle, but you can see you guys can't see all the way down to the disc space, but it's out of focus right there. And I'm just working on my discectomy.
Watch your head, Amir. I know we have a two-camera setup, super hard, but
Was that a question?
yeah, it's better. How much can you see the dural sac actually hanging down there?
Hold on one second. They have got, I've got no sound in here. I hear just a small muffle. But, okay, I think we got sound back. Go ahead.
So watch your head in that left camera, super hard, it's coaxial. Can you actually see the dural sac with your decompression?
No, with this technique, no. If you were doing a lateral corpectomy and you were taking down that amount of bone with a corpectomy, yes, you would be able to do a decompression if you were, as we mentioned kind of earlier in the day, Dr. Pham's case, how he was able to take down that burst fragment. You would need to do a corpectomy. This is, just a discectomy, and so we're leaving that posterior annulus intact. Do you have a box cutter? Any other questions?
Yeah.
No. How close are you to being done? Are you almost done?
I mean, we're done. I mean, like I said, the hard part of this, I think, technique is just getting the retractor placed. From here, it's very straightforward. I'll do my discectomy, place a cage, and the case is done.
That looks great, Amir.
It's actually a beautiful picture. Great. Okay. Should we move on to the next lecture? Are you okay there, Amir? And we'll put your
We're good.
lecture-
Like I said, this is the rest of it is straightforward. I think the nuances is really working with this retractor, which gives you the ability to work from this position. This would be draped out all posteriorly here. So rather than having to flip the patient, just bring the bed down and finish your posterior portion.
And one more question. So between prone position and a standing supine position, how much do the vessels actually fall forwards? What do you estimate now, having done this a couple of times?
So in terms of the vessels themselves, I would think that's probably less of a factor. One other thing is the abdominal content. So definitely less concern. When doing a regular lateral, you do have to be very careful working in that retroperitoneal space. And having the patient prone, having the belly fall forward, really pulls those structures out of the way and just gives you a little bit less anxiety in terms of that, very well described complication.
Amir, this is Nuj here. That was great. Really enjoyed it. I think to your point, yeah, I share the same findings. Essentially, I think the abdominal contents really do fall away in the prone position. The vessels don't seem to be an issue. I think this approach really lends itself to navigation because once you have navigation, you're able to really get a good grasp of where the disc space is. You can plan to dock directly in the trajectory of the disc space. If there's a rib to take, you can take it. And then, you know, with having the inner body of the cage under navigation, it makes it so much easier without having, you know, the emitter of the C-arm right next to one's head when you're trying to do all the work. So I love it, and I think navigation is the way to go.
Great, thank you.
All right, and we'll ask Ben when he's available to switch to our last block. We thank Amir. Applause from you. We've had Dr. Feelings on standby.